Welcome, curious minds, to another deep dive. Have you ever felt a sudden sharp pain in your abdomen and wondered, what exactly is going on in there? Or perhaps you've considered how seemingly distant organs are actually intimately connected, influencing each other's health and symptoms.
Yeah, it's quite complex.
Today, we're not just grazing the surface, we're embarking on a meticulous journey, peeling back the layers of the human body's most complex and vital central hub, the abdominal cavity. Our mission is to equip you with an elite, professional understanding of this intricate region.
That's right. Our goal in this deep dive is to transform a dense stack of anatomical knowledge, specifically excerpts from a clinical anatomy text focusing on the abdomen, into a crystal clear, truly integrated understanding.
Okay.
We're aiming for mastery, exploring everything from the precise arrangement of organs to the nuanced nerve pathways, from their fascinating embryological origins to their critical clinical implications.
Right.
Think of it as your shortcut to truly understanding the abdomen, not just memorizing facts, but grasping the why behind what you see in the clinic or even just feel in your own body.
To kick us off and put this into a real-world context, let's consider a scenario directly from our sources. Imagine a 15-year-old boy presenting with lower right abdominal pain, a fever of 101 degrees Cephia, a furred tongue, and significant tenderness and rigidity in that specific area.
Okay, classic presentation.
A diagnosis of acute appendicitis was made. Now, why did his body react with these particular symptoms, and what does this tell us about the complex systems at play inside?
Exactly.
This is where a deep dive into abdominal anatomy truly comes alive. We'll revisit this patient and many other clinical connections throughout our discussion, using our foundational knowledge to understand exactly why symptoms manifest the way they do.
Sounds like a plan.
All right, so our anatomical journey begins by understanding the vast canvas upon which all these organs reside, the abdominopelvic cavity. And this isn't two separate spaces, right? It's one continuous region of your trunk, extending from the muscular ceiling of the diaphragm all the way down to the pelvic floor.
That's a key point. It's continuous. While the pelvic inlet is often described as a boundary, it's really just an arbitrary line, kind of for descriptive purposes. In reality, it's a single, expansive internal space.
Okay.
And what's truly striking here is the sheer density and critical nature of what this continuous space houses. We're talking about almost your entire gastrointestinal tract, the liver, the intricate biliary ducts, the pancreas, the spleen, and significant portions of your urinary system.
Wow.
Plus, it's a major highway for vital blood vessels like the aorta, the inferior vena cava, and the crucial portal vein system.
So everything's packed in there.
Exactly. And the profound clinical significance of this close packing is that disease or injury in one organ can easily impact and even spread to another, leading to a cascade of diverse and sometimes confusing symptoms. For instance, an inflammation or bleeding event isn't just confined. It could become a widespread issue, making precise diagnosis challenging without this deep anatomical understanding.
So with all these vital organs packed into one continuous space, how is everything organized, lubricated, and protected? That brings us to a remarkable structure called the peritoneum.
The peritoneum.
Think of it as an incredibly intricate, thin, slippery membrane, what we call a serous membrane, that not only lines the cavity walls, but also elegantly drapes over and covers many of the organs.
Yeah, that's a good way to put it.
Okay.
Our source uses a perfect analogy. Imagine an organ being pressed against the outside of an inflated balloon.
Right.
It's covered by the balloon's surface, but it's never truly inside the balloon's air-filled space. This slippery surface is key to reducing friction, allowing organs to glide past each other without damage.
Building on that balloon analogy, we have two primary layers of this serous membrane.
You do. The parietal peritoneum is the layer that lines the actual walls of the abdominopelvic cavity itself.
Okay, the walls.
Then there's the visceral peritoneum, which is the layer that directly wraps around and covers the organs, giving them their smooth, glistening appearance.
What?
The potential space between these two layers is called the peritoneal cavity, and it is, notably, the largest cavity in the body.
The largest. Wow.
And a critical distinction arises between the sexes. In males, this peritoneal cavity is a completely closed space.
Completely closed.
However, in females, it communicates with the exterior through the uterine tubes, the uterus, and the vagina.
Okay. That's a big difference.
It is. And this anatomical detail is absolutely crucial for understanding potential routes of infection, such as how external bacteria could potentially spread directly into this cavity.
And just beneath that parietal peritoneum, there's another important layer, the extraperitoneal tissue.
Right. This isn't just empty space. It's a layer of connective tissue that can hold a significant amount of fat, particularly around organs like the kidneys.
So it's like padding.
Exactly. This fat serves a vital support and cushioning function, helping to hold those organs in place and offering some protection from external forces.
Okay, so the peritoneum isn't just one big empty bag then.
Not at all. A key insight here is that the peritoneal cavity isn't just one big open space. It's ingeniously subdivided by these folds. We have two main parts. The large greater sac, which is the main compartment, extending from the diaphragm all the way down into the pelvis.
The main one.
Then there's the smaller, more strategically placed lesser sac, also known as the omental bursa, which lies specifically behind the stomach and the lesser omentum.
Behind the stomach, okay.
But these aren't isolated compartments, though. They're in free communication.
Exactly. These two sacs are connected through a crucial oval window known as the epiploic foramen, or the opening of the lesser sac. Understanding the boundaries of this opening is incredibly important for surgeons and for tracing the spread of disease. Imagine the scene. Anteriorly, it's bordered by the free edge of the lesser omentum, which acts like a protective bundle containing three major players: the bile duct, the hepatic artery, and the portal vein.
That's the portal triad, essentially.
Right. Posteriorly, you'll find the inferior vena cava. Superiorly, it's framed by a small part of the liver called the caudate process. And inferiorly, it's the first part of the duodenum.
Knowing those precise landmarks is key to navigating this area, whether in surgery or when trying to understand how a pathology might be extending from one peritoneal sac to another.
This leads us to a fundamental classification in abdominal anatomy: how organs relate to their peritoneal covering. We use the terms intraperitoneal and retroperitoneal.
Right, a really important distinction. An organ is considered intraperitoneal if it's almost totally covered with visceral peritoneum and essentially suspended within the peritoneal cavity by a fold of peritoneum.
Like the stomach.
Exactly. Think of the stomach, the jejunum, the ileum, and the spleen. They're highly mobile because of this. Conversely, retroperitoneal organs lie behind the parietal peritoneum and are only partially covered on one surface.
So behind the scenes, kinda.
Pretty much. The pancreas and the ascending and descending parts of the colon are excellent examples. This distinction isn't just academic. It profoundly impacts an organ's mobility, how infections might spread from or to it, and how easily it can be accessed surgically.
Ah, okay. So a retroperitoneal organ would be less mobile.
Generally, yes, and less prone to a widespread peritoneal infection compared to an intraperitoneal one.
Beyond just covering organs, the peritoneum creates these incredible two-layered folds that act as vital bridges. These are the peritoneal ligaments, ommenta, and mesenteries.
Absolutely crucial structures. Functionally, they do so much more than just suspend organs within the cavity.
Yeah.
They are critical avenues for blood vessels, lymphatics, and nerves to reach the viscera, like internal highways.
Highways, I like that.
Plus, they're often significant storage sites for fat, especially in certain areas.
Indeed. To break those down, peritoneal ligaments are specific folds that typically connect solid organs like the liver to the abdominal walls.
Okay.
For example, the liver is tethered to the diaphragm by structures like the falciform, coronary, and triangular ligaments. These aren't just flimsy attachments, they're integral to the liver's positioning and stability.
Then we have the ommenta, which are also two-layered folds, but they specifically connect the stomach to other organs. The greater omentum is quite remarkable.
It is, isn't it?
It hangs down like a protective apron from the greater curvature of the stomach, extending in front of the small intestines, and then folds back to attach to the transverse colon. Our source affectionately calls it the abdominal policeman.
Huh. I love that. The abdominal policeman.
Because of its incredible role in localizing infection, which we'll discuss further in its clinical context. The lesser omentum, on the other hand, is a more superior fold that connects the lesser curvature of the stomach and the first part of the duodenum to the undersurface of the liver.
Got it. And finally, the mesenteries.
These are two-layered folds of peritoneum that specifically connect parts of the intestines to the posterior abdominal wall. This group includes the extensive mesentery of the small intestine, which suspends the jejunum and ileum, as well as the transverse mesocolon for the transverse colon, and the sigmoid mesocolon for the sigmoid colon.
So they hold the intestines up.
Exactly. These structures are critical not only for supporting the intestines, but also for carrying their neurovascular supply, making them vital anatomical landmarks for both function and disease.
Beyond the main greater and lesser sacs, the abdomen contains even smaller but clinically very important pockets of peritoneum. These are the peritoneal recesses, spaces, and gutters.
Little pockets and pathways.
Think of them as the body's natural collection points or pathways for fluids. For instance, you have the subphrenic spaces located between the diaphragm and the liver,
Right above the liver.
and the pericolic gutters that run along the sides of the ascending and descending colons.
And these aren't just anatomical curiosities. Their clinical significance cannot be overstated. These spaces and gutters are absolutely critical sites for the collection and, importantly, the movement of infected peritoneal fluid.
Okay.
Our source provides a vivid illustration. Peritoneal fluid normally flows upward to the subphrenic spaces, where it's rapidly absorbed. However, in cases of peritonitis inflammation, the peritoneum inflammatory fluid tends to collect in these same subphrenic spaces or in the pelvis, depending on the patient's position.
So position matters.
Immensely. This is precisely why nursing a patient with peritonitis in a 45-degree inclined position is a common practice. It helps the fluid gravitate down to the pelvic cavity, where the rate of toxin absorption into the body is significantly slower.
Wow, that's clever. Like using gravity to help?
Exactly. It offers a protective mechanism against widespread systemic infection.
It's incredible how the body has these built-in systems for managing potential threats. Let's delve a bit more into the functions of the peritoneum itself. It secretes a pale yellow, slightly sticky fluid containing white blood cells. This peritoneal fluid is essential.
Lubricant.
It lubricates the surfaces, allowing the mobile abdominal organs to glide easily over one another without friction. And this fluid isn't static, it's constantly in motion, aided by the movements of the diaphragm, the abdominal muscles, and the wave-like contractions of the intestines, peristalsis.
Right, it's dynamic. Any particulate matter introduced into the lower peritoneal cavity rapidly moves up to the subphrenic spaces, where it's quickly absorbed into the lymphatic system, with the diaphragm's respiratory movements playing a key role in aiding this lymph flow.
Beyond lubrication and fluid transport, the peritoneum exhibits a remarkable protective mechanism. Its tendency to adhere in the presence of infection.
This is fascinating. The greater omentum, which we earlier called the abdominal policeman,
Our policeman.
and is kept constantly moving by intestinal peristalsis, plays a pivotal role here. When an organ becomes infected, for instance, an inflamed appendix or a perforating gastric ulcer, the omentum actively migrates to that site, wrapping itself around the infected organ to seal off and localize the infection.
So it walls it off.
Precisely. This crucial action prevents the infection from spreading throughout the entire peritoneal cavity, effectively averting a much more serious diffuse peritonitis. This is why in young children, whose greater omentum is still poorly developed, they are less protected against widespread infection.
No, that makes sense. Now let's tie this directly back to our 15-year-old boy with acute appendicitis. Understanding the peritoneal nerve supply and how pain is differentiated is absolutely key to grasping his symptoms.
Couldn't agree more.
The parietal peritoneum, which lines the cavity walls, is highly sensitive to pain, temperature, touch, and pressure. Its nerve supply comes from the somatic nerves, the same nerves that supply your skin and muscles.
Somatic nerves, like the ones for your skin.
Right. This means that pain originating from the parietal peritoneum is typically severe and, crucially, precisely localized. That's the sharp, localized pain in the right lower quadrant our patient felt.
Okay, sharp and localized.
In stark contrast, the visceral peritoneum, which covers the organs themselves, is sensitive only to stretch and tearing, not to touch, pressure, or temperature.
Only stretch and tearing.
Yeah. It's supplied by visceral afferent nerves. Therefore, overdistension of an organ or pulling on its mesenteries causes a dull, poorly localized pain, often referred to the midline.
Dull, vague, midline. That difference is fundamental in diagnosing abdominal conditions.
To truly understand this complex system, it helps to look at its origins. The embryological development of the peritoneum shows us how this intricate arrangement comes to be.
Yeah, going back to the beginning, the peritoneal cavity itself derives from what's called the intraembryonic accellum in the early embryo. Early on, developing ventral and dorsal mesenteries initially divide the cavity. As the gut and organs grow and rotate during development, these mesenteries essentially twist and fold, giving rise to the peritoneal ligaments, ommenta, and mesenteries we see in the adult.
So the twisting and folding creates the final structure.
Pretty much. For instance, the lesser sac, that space behind the stomach, actually forms as a direct result of the extensive growth of the right lobe of the liver and the subsequent rotation of the stomach. These developmental twists and turns dictate the adult anatomy and, consequently, profoundly influence patterns of disease spread and how pain is referred.
It all ties back to development. Fascinating. All right, our deep dive continues as we journey into the heart of digestion, the gastrointestinal tract. And let's start at the very beginning of its abdominal portion with the abdominal esophagus, the gateway.
Just a tiny bit in the abdomen.
Right. While most of the esophagus lies within the chest, a short segment, about half an inch long, makes its appearance in the abdomen. It pierces the diaphragm slightly to the left of the midline and almost immediately enters the stomach. It's deeply placed, lying behind the left lobe of the liver.
And what's crucially important here is the gastroesophageal sphincter. Unlike other sphincters in the GI tract, there is no distinct anatomic ring of muscle that you can point to at the lower end of the esophagus.
No visible muscle ring.
Nope. Instead, its function is maintained by a strong physiologic sphincter formed by the circular smooth muscle in that region. This sphincter's closure is under vagal nerve control, augmented by the hormone gastrin, and reduced by others like secretin.
So it's functional, not structural.
Exactly. This intricate control system is vital in preventing the reflux of stomach acid back into the esophagus, a common problem when this physiological mechanism fails.
We're talking about conditions like gastroesophageal reflux disease, or GERD, right? Where chronic reflux of stomach acid causes heartburn, inflammation, and can even lead to changes in the esophageal lining.
Yeah, potentially serious changes, increasing the risk of certain cancers.
Increasing the risk of certain cancers. And here's where it gets really interesting, particularly regarding the concept of portal hypertension, bleeding esophageal varices.
Yes, a major clinical issue.
This is a major clinical concern because the lower third of the esophagus is a site of an important connection between two major circulatory systems, what we call a portal systemic anastomosis.
A connection point.
Right. Here, the esophageal veins that normally drain to the portal system connect with veins that drain to the systemic circulation. If the portal vein becomes obstructed, for example, due to cirrhosis of the liver, blood backs up.
Pressure builds,
Causing these delicate esophageal veins to become engorged and varicose. These can then rupture, leading to severe vomiting of blood, or hematemesis, which is a life-threatening emergency.
Absolutely life-threatening. This highlights the crucial connections between the digestive and circulatory systems, doesn't it?
It really does. Moving from the esophagus, we arrive at the stomach, a truly remarkable organ with a triple role.
Storage, mixing, and delivery control.
Exactly. It's a powerful food storage unit, capable of holding a significant volume. It's a mixing and churning powerhouse, blending food with gastric secretions to create a semi-fluid mixture called chyme. And critically, it precisely controls the rate of this chyme's delivery to the small intestine, ensuring optimal digestion and absorption downstream.
Its location and shape are quite dynamic. It's typically J-shaped, mobile, but relatively fixed at its ends. It primarily occupies the left upper abdomen, largely shielded by your lower ribs.
So it hides under the ribs mostly.
Pretty much. Its shape varies considerably even in the same person, depending on its contents and body position. Anatomically, it's divided into the dome-shaped fundus, the main body, the pyloric antrum, and the pylorus, which is the most tubular part, and features a thick, muscular pyloric sphincter.
The stomach has two distinct curvatures. The shorter, lesser curvature on its right, suspended from the liver by the lesser omentum, and the much longer, greater curvature on its left, connected to the spleen and transverse colon by other peritoneal folds.
Right. And the pyloric sphincter is a key player here. It's both an anatomic, a visible muscle ring, and physiologic, a functional valve, sphincter, precisely controlling the outflow of gastric contents into the duodenum. It's influenced by both nerve signals and local hormones.
And inside.
Internally, the stomach's lining has numerous longitudinal folds, or rugae, that flatten out when it's distended. Its muscular wall is robust, with 3 layers of muscle fibers, allowing for powerful mixing actions.
Understanding its relations is vital for clinical interpretation. The stomach is quite centrally located, meaning it touches many surrounding organs.
Yeah, it's crowded in there.
Anteriorly, it's related to the abdominal wall, the lower ribs, the diaphragm, and the left lobe of the liver. Posteriorly, it's in close contact with the lesser sac, the spleen, the left suprarenal gland, the left kidney, the splenic artery, and the pancreas.
These intricate relationships are crucial. For example, a penetrating gastric ulcer on the posterior wall can easily involve the pancreas or perforate into the lesser sac, demonstrating how pathology in one organ can directly impact surrounding structures.
The blood supply to the stomach is entirely derived from branches of the celiac artery, ensuring it has a rich supply to support its intense digestive activity.
Very rich supply. Venous drainage mirrors this, with all blood eventually making its way into the portal system before going to the liver. Lymphatic drainage follows a similar pattern along the arteries and eventually all drains to the celiac lymph nodes on the posterior abdominal wall.
And that lymph drainage is important for cancer spread.
Critically important, unfortunately. This intricate lymphatic network is highly significant for understanding the spread of gastric cancer. Its nerve supply is entirely autonomic, meaning it's involuntary. Sympathetic nerves primarily carry pain signals, while parasympathetic nerves, from the vagus nerve, stimulate gastric secretions and muscle movement.
Now, for the clinical connections related to the stomach, gastric ulcers are often found near the lesser curvature. A chronic ulcer can penetrate the muscular coats and involve the peritoneum,
Leading to adhesions.
leading to adhesion to neighboring organs like the pancreas, or worse, perforation into the lesser or greater sacs. A perforation can cause potentially fatal hemorrhage or widespread peritonitis.
Yeah, nasty stuff.
Gastric pain itself, caused by stretching or spasmodic contraction, is often referred to the epigastrium, the upper central abdomen. This is carried by those sympathetic afferent nerves we discussed earlier.
Referred pain again. In the unfortunate case of stomach cancer, the extensive lymphatic network means rapid dissemination. This often necessitates a total gastrectomy, a radical operation involving removal of the stomach and often adjacent structures and lymph nodes, highlighting the aggressive nature of these malignancies.
That sounds intense.
It is. Understanding the embryological development of the stomach helps explain much of its adult anatomy. It develops as a simple swelling of the primitive gut tube, then undergoes a significant rotation.
That rotation seems key.
It really is. It shifts its position and creates the lesser sac behind it and shapes the omenta. A significant congenital anomaly related to this is congenital hypertrophic pyloric stenosis, which occurs in infants. It involves a thickening of the pyloric sphincter muscle, leading to forceful vomiting, and is thought to be due to issues with nerve cells in the area.
Moving from the stomach, we enter the small intestine, which, despite its name referring to its diameter, is the longest part of the alimentary canal.
Yeah, really long.
Extending from the pylorus to where it meets the large intestine, this is the primary site for most digestion and absorption. It's functionally divided into three regions: the duodenum, the jejunum, and the ileum.
First up is the duodenum, which is both fixed and vital. This C-shaped tube, about 10 inches long, wraps around the head of the pancreas.
C-shaped, okay.
What's crucial here is that while its very first inch is mobile and covered by peritoneum, the remainder is distinctively retroperitoneal, meaning it's rigidly fixed to the posterior abdominal wall.
Mostly fixed them.
Mostly fixed. This makes it particularly vulnerable to crush injuries. It also serves as the critical junction where the bile and pancreatic ducts deliver their digestive secretions.
So where the juices come in.
Exactly. Its four distinct parts have important relations. For example, the first part is close to the liver and gallbladder, while the third part is crossed by major blood vessels, the superior mesenteric artery and vein, making it a point of vulnerability. Its lining is smooth initially, but then features numerous circular folds called pliques circulares.
After the duodenum, we have the jejunum and ileum, which together stretch an impressive 20 feet.
20 feet. That's amazing.
These sections are quite mobile, attached to the posterior abdominal wall by a fan-shaped fold of peritoneum known as the mesentery of the small intestine. This mesentery isn't just a support structure, it's a vital conduit for the superior mesenteric artery and vein, lymphatics, and nerves, connecting the intestine to the rest of the body's systems.
The lifeline for the small bowel. In a healthy person, the jejunum and ileum have key differences. The jejunum typically lies in the upper left of the abdominal cavity, while the ileum occupies the lower right and extends into the pelvis.
Location difference, okay.
The jejunum is wider, thicker walled, and redder, with more prominent internal folds. In contrast, the ileum is thinner walled and has less prominent folds. Their blood supply also differs in how the vessels branch. The jejunum has fewer, larger arterial arches, arcades, and longer, straighter vasa recta, feeder vessels.
Long, straighter ones in the jejunum.
While the ileum has many small arcades and numerous short vasa recta. Fat distribution in the mesentery also varies, and the ileum contains visible aggregations of lymphoid tissue called Peyer's patches, important for immunity.
The blood supply to the jejunum and ileum, along with the lower half of the duodenum, is primarily from the superior mesenteric artery, with venous drainage mirroring this to the superior mesenteric vein and then the portal system.
all heading to the portal vein.
Lymph drains to the superior mesenteric nodes, and nerve supply comes from the superior mesenteric plexus, encompassing both sympathetic and parasympathetic vagus fibers.
Now, for some critical clinical connections related to the small intestine, the duodenum's fixed retroperitoneal position makes it highly vulnerable to trauma, particularly crush injuries against the vertebral column.
Right, because it's pinned back there.
Exactly. Duodenal ulcers frequently occur in the first inch. An anterior perforation can spill fluid into the abdominal cavity, while a posterior perforation risks eroding a major artery, the gastroduodenal artery, leading to severe hemorrhage.
That sounds bad.
Very bad. The pain fibers from the jejunum and ileum cause referred pain to the umbilical region. This dull, poorly localized pain shifts to a sharp, precisely localized somatic pain if the parietal peritoneum becomes inflamed.
The same shift we saw with the appendix.
Precisely. Lastly, meckel diverticulum is a significant congenital anomaly, a small pouch in the ileum found in about 2% of the population, often containing ectopic gastric mucosa which can cause bleeding and pain or form fibrous bands that lead to intestinal obstruction.
Wow, 2%. That's fairly common.
Relatively speaking, yes. The embryological development of the duodenum and midgut is a complex dance of growth and rotation. The midgut loop itself, which gives rise to most of the small intestine and part of the large, undergoes a physiological herniation outside the abdomen into the umbilical cord.
It pops out.
Temporarily, yes. While outside, it rotates 90 degrees counterclockwise, and upon its return, it completes another 180-degree counterclockwise rotation for a total of 270 degrees. This elaborate process is fundamental to the final anatomical arrangement and the formation of various peritoneal structures.
270 degrees.
Quite a twist. This complex rotation can lead to several congenital anomalies. Duodenal atresia or stenosis occurs if the lumen, which temporarily closes during development, fails to reopen, leading to bile-stained vomiting shortly after birth.
So it stays blocked.
Right. Midgut loop malrotation, involving incomplete or reversed rotation, can cause duodenal obstruction or abnormal positioning of the large intestine, leading to diagnostic confusion for conditions like appendicitis. The persistence of the vitelline duct, which normally closes, can lead to that meckel diverticulum we just mentioned, or fibrous bands that cause intestinal obstruction.
Shifting to the large intestine, this final segment of the alimentary canal extends from the ileum to the anus. Its primary functions are crucial for our hydration and waste management, the absorption of water and electrolytes, and the storage of undigested material until it can be expelled as feces.
Water absorption and storage, basically. When distinguishing the large intestine from the small intestine, there are several key external differences. The large intestine typically has a wider caliber. A distinctive feature are the Tenea coli 3 discrete bands of longitudinal muscle, which are absent in the small intestine.
Those three stripes.
Exactly. You'll also find omental appendices, or appendices epiploicae, which are fatty tags on the large intestine. And finally, the large intestine has characteristic haustra, which are sacculations or folds, giving it a segmented appearance, unlike the smooth wall of the small intestine.
Foster, okay.
Internally, the small intestine has numerous circular folds and tiny finger-like projections called villi, both absent in the large intestine.
Let's focus on the beginning of the large intestine, the cecum. This is a blind-ended pouch located in the lower right abdomen, just below where the small intestine joins.
Very beginning pouch.
It's fully covered by peritoneum, giving it considerable mobility, but unusually, it lacks its own mesentery. A key landmark is that the Tenea coli, those three longitudinal muscle bands, converge at the base of the appendix, which is vital for locating it.
Points right to it. The ileocecal valve acts as a physiological sphincter, controlling flow between the small and large intestines.
Now, onto the appendix, or vermiform appendix, a small worm-shaped tube rich in lymphoid tissue, typically a few inches long.
The infamous appendix.
Its base is consistently attached to the posteromedial cecum, about an inch below the ileocecal junction. It has a complete peritoneal covering and its own mesentery, which carries its vital blood vessels and nerves. Clinically, the base can be located on the anterior abdominal wall at McBurney's point,
The classic spot.
about 1/3 of the way up the line from your right hip bone to your belly button.
What's absolutely critical for diagnosing conditions like appendicitis is the highly variable positions of the appendix tip. It can hang down into the pelvis, be coiled up behind the cecum, retrocecal, project upward, or lie in front of or behind the small intestine.
It can be anywhere.
Pretty much. This variability explains why appendicitis pain can sometimes present in unusual locations, causing diagnostic confusion.
The appendix's unique anatomy also explains its predisposition to infection and perforation. It's a long, narrow, blind-ended tube which encourages stasis of contents.
Things get stuck.
Yeah.
Mm-hmm.
It has abundant lymphoid tissue, making it prone to inflammation, and its lumen often becomes obstructed by hardened intestinal contents. Crucially, its blood supply comes from a single artery, with virtually no collateral connections.
A single end artery. That's risky.
Very risky. This means that inflammation can easily compress its blood supply, leading to tissue death and ultimately perforation. This perforation then results in infection of the greater sac peritoneum, where the abdominal policeman, the greater omentum, attempts to localize the infection.
Our policeman trying to contain the situation again.
And this brings us full circle to our 15-year-old patient. The appendicitis pain he experienced started as visceral pain, a dull, poorly localized sensation in the umbilical region as the appendix lumen distended.
That dull, vague midline pain.
Right. But later, as the inflammation spread to irritate the highly sensitive parietal peritoneum, the pain became sharp, precise, severe, and localized in the right lower quadrant, leading to the tenderness and rigidity he presented with. This shift in pain is a classic diagnostic sign.
Classic shift. Visceral to somatic. Beyond the cecum and appendix, we have the various colon sections. The ascending colon is about 5 inches long, fixed and retroperitoneal. The transverse colon is a wide, U-shaped mobile segment.
Mobile transverse colon.
The descending colon is about 10 inches long, also fixed and retroperitoneal. Finally, the sigmoid colon is an S-shaped loop, highly mobile due to its mesentery, which then joins the rectum.
S-shaped and mobile sigmoid.
The blood supply to the large intestine follows a clear pattern tied to its embryological origins. The right side, cecum, appendix, ascending colon, and proximal 2/3 of the transverse colon, is supplied by branches of the superior mesenteric artery.
SMA territory.
The left side, distal 1/3 of the transverse colon, descending and sigmoid colon, is supplied by branches of the inferior mesenteric artery.
IMA territory.
A crucial marginal artery provides anastomoses, or connections, along the entire large intestine, offering a vital collateral blood supply if one of the main arteries is blocked.
Like a backup route.
Exactly. Venous drainage mirrors this, leading to the superior or inferior mesenteric veins and eventually joining the portal system. Nerve supply also divides along this same line, with the right side influenced by the superior mesenteric plexus and the left side by the inferior mesenteric plexus.
The clinical connections for the large intestine are extensive. Colonoscopy is a vital procedure for early colorectal cancer detection. Colon trauma is common at the mobile fixed junctions due to blunt injuries.
Where mobile meets fixed, that's a weak point.
Large bowel cancer spreads via lymphatics first, then the portal circulation to the liver later, necessitating early surgical removal. We also see conditions like diverticulosis and diverticulitis, where small pouches in the colon wall become inflamed.
Very common, diverticulosis.
The extreme mobility of the sigmoid colon can lead to volvulus, where it twists around its mesentery, risking blood supply cutoff. And intussusception, common in children, is the telescoping of one bowel segment into an adjacent one, risking gangrene.
Telescoping, yeah. The embryological development of the large intestine further illuminates these conditions. The cecum and appendix develop from a diverticulum of the midgut. Anomalies like an undescended cecum or failure of rotation can lead to the appendix being in an unusual position, such as the left abdomen.
Left-sided appendicitis pain, that's confusing.
Extremely confusing, which creates significant diagnostic challenges when appendicitis occurs, causing pain in an unexpected location.
As we continue our deep dive, we're now moving beyond the main digestive tube to explore the accessory organs that are absolutely essential to its function, as well as the vital urinary system. Let's start with the largest gland in the body, the liver, the body's chemical plant and furler.
Indeed, the liver is an organ of incredible versatility. Its functions are vast. It produces and secretes bile, crucial for fat digestion. It's a central hub for metabolism, intricately involved in processing carbohydrates, fats, and proteins.
The metabolic powerhouse.
Absolutely.
Okay.
And it acts as a highly efficient filter, removing bacteria and foreign particles from the blood that has just arrived from the GI tract. Beyond that, it synthesizes important substances like heparin and performs essential detoxification functions. It's truly a chemical plant and a filter rolled into one.
Its location is quite imposing. It's a large, soft, pliable, and highly vascular organ that occupies the upper right abdomen, mostly under the right lower ribs. Its upper surface is molded to the diaphragm, while its irregular lower surface is molded to and in contact with adjacent organs like the stomach, duodenum, and right kidney.
Traditionally, the liver is divided into a large right lobe and a smaller left lobe. However, from a functional perspective, which is more relevant clinically for surgeons,
Functional lobes, right?
the liver is divided into segments based on their distinct arterial, portal, and duct distributions.
Hmm.
This functional division is crucial for surgical resections, allowing surgeons to remove specific portions of the liver affected by trauma or tumors while preserving function.
So they can take out just one part.
Precisely. The porta hepatis, or hilum of the liver, on its undersurface is a busy entryway, transmitting the right and left hepatic ducts, carrying bile, branches of the hepatic artery, the portal vein, and associated nerves and lymph nodes.
Speaking of connections, the liver has several important peritoneal ligaments. The falciform ligament, for example, runs from the umbilicus to the liver and contains the ligamentum teres,
That umbilical vein remnant.
which is the remnant of your umbilical vein from fetal life. Other ligaments, like the coronary and triangular ligaments, secure the liver to the diaphragm, creating an area of the liver not covered by peritoneum known as the bare area.
The blood supply to the liver is unique and dual. It receives both oxygenated blood from the hepatic artery, a branch of the celiac artery, and, crucially, nutrient-rich, deoxygenated venous blood from the portal vein, which drains most of the GI tract, spleen, and pancreas.
Both artery and vein blood.
Yes, a dual supply. Both enter at the porta hepatis and branch into the liver, mixing before eventually draining into the hepatic veins, which empty directly into the inferior vena cava. This dual supply is critical for its metabolic and detoxification functions, providing both fuel and raw material.
The liver is also an astonishingly prolific lymph producer, generating about 1/3 to 1/2 of all body lymph.
Huge amount of lymph.
Lymph vessels drain to nodes at the porta hepatis and then to the celiac nodes. Its nerve supply, consisting of sympathetic and parasympathetic nerves, coordinates its vast functions.
Let's discuss some vital clinical connections for the liver. Its soft, friable nature and close proximity to the lower ribs make it highly susceptible to trauma from fractures or penetrating wounds, leading to severe hemorrhage.
Easily injured, then.
Very easily. The segmental distribution of bile ducts and vessels allows for partial hepatectomy in cases of trauma or localized tumors, as surgeons can remove affected segments while preserving function. Liver biopsy is a common diagnostic procedure, often requiring a needle insertion through the right 8th or 9th intercostal space during full expiration to minimize the risk of lung damage.
Gotta avoid the lung.
Definitely. And the subphrenic spaces, those potential spaces above the liver, can accumulate gas or fluid, such as from a perforated gastric ulcer, which can be detected clinically.
The embryological development of the liver begins as a solid bud from the primitive gut tube, growing into the developing diaphragm area. As it develops, fetal blood vessels become the liver sinusoids, and the bud canalizes to form the bile ducts. A critical anomaly here is biliary atresia,
Ah, yes, a serious one.
where the bile ducts fail to canalize during development. This leads to jaundice and liver failure shortly after birth if not surgically corrected.
From the liver, we now turn to its associated structures. The biliary tree and gallbladder, which are responsible for bile storage and delivery. Bile is continuously produced by the liver cells, and this system is designed to drain, store, and then deliver that bile to the duodenum precisely when needed for fat digestion.
The duct system begins with tiny ducts within the liver, which eventually unite to form the right and left hepatic ducts, draining their respective lobes. These then merge to form the common hepatic duct. This duct is then joined by the cystic duct from the gallbladder to form the final bile duct.
And the bile duct's course is critical. It descends, initially within the free margin of the lesser omentum, then passes behind the first part of the duodenum, and finally descends in a groove on the posterior surface of the head of the pancreas.
Runs behind the pancreas head?
Right. Here, it typically unites with the main pancreatic duct to form the hepatopancreatic ampulla, or ampulla of Vater, which then opens into the duodenum. This opening is surrounded by the sphincter of Oddi, which regulates bile flow. However, variations in this arrangement are common and important for clinical understanding.
The gallbladder itself is a pear-shaped sac adhering to the undersurface of the right lobe of the liver, with a capacity of about 30-50 milliliter. It's divided into a fundus, body, and neck. The fundus projects below the liver's inferior border, often contacting the anterior abdominal wall.
So you might be able to feel it if it's inflamed. The gallbladder's function is multifaceted. It stores and concentrates bile by absorbing water, and it secretes mucus. Its contraction and emptying are primarily stimulated by fatty foods entering the duodenum, which triggers the release of the hormone cholecystokinin, CCK.
CCK for contraction.
CCK causes the gallbladder to contract and simultaneously relaxes the sphincter of Oddi, allowing concentrated bile to enter the duodenum, where bile salts are essential for emulsifying and digesting fats.
Blood supply to the gallbladder comes via the cystic artery, a branch of the right hepatic artery. Lymph drains to the cystic lymph node, then to hepatic and celiac nodes. Its nerve supply is from the celiac plexus. The cystic duct connects the gallbladder neck to the common hepatic duct. It contains a spiral valve, a mucosal fold that helps keep its lumen constantly open.
Let's consider the crucial clinical connections here. Gallstones, cholelithiasis, are often asymptomatic, but can cause biliary colic agonizing pain due to smooth muscle spasm, typically referred to the right upper abdomen or epigastrium.
That referred pain again?
Yep. Obstruction by gallstones can lead to jaundice, yellowing of skinnies, and impaction in the ampulla of Vater can even cause pancreatitis. Gallstones can also ulcerate through the gallbladder wall into adjacent intestines, potentially causing intestinal obstruction.
Acute cholecystitis, inflammation of the gallbladder, produces pain in the right upper quadrant. If it irritates the subdiaphragmatic parietal peritoneum, which is supplied by the phrenic nerve, this can lead to classic referred pain over the right shoulder.
The shoulder tip pain, that's a classic sign.
This is a powerful example of how nerve pathways can trick the brain into feeling pain at a distant site. For cholecystectomy, surgical removal of the gallbladder, surgeons must be acutely aware of anatomical variations in the cystic artery and its relation to the bile ducts to prevent accidental ligation of other crucial ducts.
Gotta watch out for those variations. The embryological development of the gallbladder originates as an outgrowth of the hepatic bud. Anomalies include its complete absence or a double gallbladder. Surgical complications can arise from variations in the cystic duct. Rare choledochal cysts, areas of weakness in the bile duct wall, can also form and cause obstructive jaundice.
Next, we dive into the pancreas, a remarkable dual-function gland. It acts as both an exocrine gland, producing a potent cocktail of enzymes essential for hydrolyzing proteins, fats, and carbohydrates,
Digestive enzyme.
and an endocrine gland, with its islets of Langerhans secreting the vital hormones insulin and glucagon, which are key players in carbohydrate metabolism.
Exocrine and endocrine. This soft lobulated gland is retroperitoneal, situated on the posterior abdominal wall, primarily in the upper central and left abdomen, crossing the transpyloric plane. It's divided into a disc-shaped head nestled within the duodenal concavity, which includes an unsquittate process extending behind major blood vessels.
Head in the C-loop of the duodenum.
Exactly. The constricted neck connects the head to the body, lying anterior to the portal vein and superior mesenteric artery origin. The triangular body extends upward and to the left, while the tail projects forward within a peritoneal fold, making contact with the hilum of the spleen.
The pancreas has some crucial relations due to its deep position. Anteriorly, it's related to the transverse colon, the lesser sac, and the stomach. Posteriorly, it's intimately connected with the bile duct, the portal and splenic veins, the inferior vena cava, the aorta, the origin of the superior mesenteric artery, and the left kidney and suprarenal gland.
Really deep and central. These deep relations mean that pancreatic pathologies can easily affect surrounding structures and vice versa, making diagnosis challenging.
The pancreatic ducts are the conduits for its exocrine secretions. The main pancreatic duct typically originates in the tail, traverses the length of the gland, and joins the bile duct to open at the major duodenal papilla. An accessory duct, when present, usually drains the upper head and opens separately at the minor duodenal papilla.
Blood supply comes from the splenic and pancreaticoduodenal arteries, with venous drainage to the portal system. Lymph drains to the celiac and superior mesenteric nodes, and its nerve supply is from sympathetic and vagal parasympathetic fibers.
The clinical connections for the pancreas underscore its anatomical challenges. Its deep location complicates diagnosis, with pain often referred to the back.
Pain in the back is common.
Pancreatic disease can mimic stomach or colon issues, and inflammation can spread to the lesser sac, forming pseudocysts. While well protected, trauma from blunt force can crush it against the vertebral column, or gunshot stab wounds can damage it, leading to the release of activated enzymes that cause acute peritonitis.
Nasty chemical burn, essentially. Critically, cancer of the pancreatic head, due to its close relation to the bile duct, frequently causes obstructive jaundice. And the presence of the pancreatic tail within its ligament means it's vulnerable to damage during splenectomy, leading to enzyme release and tissue digestion.
Gotta be careful during spleen surgery then.
Absolutely. The embryological development of the pancreas is a testament to the intricate folding and fusion of the primitive gut. It develops from dorsal and ventral buds arising from the foregut. The rotation of the stomach and duodenum brings these buds into contact and they fuse.
Fusion creates the final pancreas.
Right. Anomalies include annular pancreas, where the ventral bud encircles the duodenum, causing obstruction in newborns, and ectopic pancreas, where pancreatic tissue is found in other GI locations, potentially causing obstruction.
Next, we arrive at the spleen, a fascinating reddish organ that is the largest single mass of lymphoid tissue in the body. It's important to remember it's not part of the GI tract itself, despite its close anatomical relationships.
Yeah, it's lymphoid, not digestive. Oval-shaped and with a characteristic notched anterior border, it lies nestled under the left half of the diaphragm, typically along the long axis of the 10th left rib. Its lower pole is normally not palpable on clinical examination.
The spleen is completely surrounded by peritoneum, which forms two key ligaments originating from its hilum. The gastrosplenic omentum connects the spleen to the stomach, carrying vessels. The splenorenal ligament connects the spleen to the left kidney, transmitting the splenic vessels and the tail of the pancreas.
Remember, the pancreas tail is in there. These peritoneal connections are critical for its stability and vascular supply. Its relations are anteriorly, the stomach, tail, the pancreas, and left large intestine. Posteriorly, the diaphragm, lung, and ribs.
Its blood supply comes from the large, tortuous splenic artery, the largest branch of the celiac artery. The splenic vein leaves the hilum, runs behind the pancreas, and critically joins the superior mesenteric vein behind the neck of the pancreas to form the portal vein.
Forming the portal vein, that's a key junction. Lymph drains to the celiac nodes, and its nerves are from the celiac plexus.
The clinical connections for the spleen include splenic enlargement, or splenomegaly, where it extends downward and medially with its notched anterior border often palpable.
You might feel that notch. This is common in conditions like portal hypertension due to venous congestion. Despite appearing well protected, the spleen is vulnerable to trauma from blunt injuries, such as in automobile accidents, leading to laceration and potentially severe hemorrhage.
So it bleeds a lot if injured.
Very much so. The embryological development of the spleen shows it arises as a thickening of tissue in the dorsal mesentery. Its characteristic notches are a reflection of the incomplete fusion of multiple masses. The gastrosplenic omentum and splenorenal ligament are remnants of this dorsal mesentery. An interesting anomaly is a supernumerary spleen, found in about 10% of people, often as small extra spleens.
The extra spleens.
Yeah, these can hypertrophy after a main splenectomy, causing a recurrence of symptoms for the original condition.
Our deep dive now shifts to the urinary system, starting with the kidneys, the body's filtration system.
The body's filters. These two reddish-brown retroperitoneal organs are exquisitely designed to excrete most of the waste products of metabolism, precisely control water and electrolyte balance, and maintain the critical acid-base balance of the blood. The urine they produce travels via the ureters to the urinary bladder.
They're situated high up on the posterior abdominal wall, one on each side of the vertebral column, largely under the cover of the lower ribs. The right kidney typically sits slightly lower than the left due to the large size of the right lobe of the liver.
The right one's a bit lower. They also exhibit mobility, moving downward by as much as an inch with diaphragm contraction during respiration. The hilum, a vertical slit on the medial concave border, extends into the renal sinus. It transmits from front to back the renal vein, two branches of the renal artery, the ureter, and the third branch of the renal artery, a memorable order often recalled by the mnemonic VAUA.
VAUA, got it.
The kidneys have several important coverings that contribute to their support and protection. Directly enveloping the kidney is a fibrous capsule. Outside this is the perirenal fat, which in turn is enclosed by the renal fascia, a condensation of connective tissue that also encloses the suprarenal glands. External to the renal fascia is the perirenal fat.
Layers of fat and fascia.
Exactly. Together, these layers are crucial for supporting the kidneys and holding them in their retroperitoneal position.
Internally, each kidney has an outer dark brown cortex and an inner light brown medulla. The medulla is organized into about a dozen renal pyramids with their apices called renal papillae, projecting medially. The cortex extends between adjacent pyramids as renal columns.
Within the renal sinus, the expanded upper end of the ureter, the renal pelvis, divides into major and minor calyces, which collect urine from the papillae.
The important relations of the kidneys are extensive and vary slightly between the right and left sides. For the right kidney, anteriorly, it's in contact with the suprarenal gland, liver, and second part of the duodenum.
touching the liver and duodenum. This means issues like liver enlargement or a severe duodenal ulcer could directly affect it, and vice versa. Posteriorly, it rests on the diaphragm and muscles of the back.
And the left kidney.
For the left kidney, anteriorly, it's related to the suprarenal gland, spleen, stomach, and pancreas. Posteriorly, it also rests on the diaphragm and back muscles. Understanding these immediate neighbors is crucial for diagnosis.
The blood supply is robust, with each renal artery arising from the aorta. These arteries divide into segmental arteries, which then branch down to tiny afferent glomerular arterioles that filter blood. The renal vein emerges anterior to the artery and drains into the inferior vena cava.
Lymph drains to the lateral aortic nodes, and its nerve supply comes from the renal sympathetic plexus, with pain signals traveling with nerves to the spinal cord.
When it comes to clinical connections for the kidneys, their mobility is maintained by intra-abdominal pressure surrounding fat and fascia. However, excessive mobility, often due to reduced perirenal fat, can lead to renal colic from ureter kinking.
A dropped kidney can cause pain. Despite being well protected by ribs and muscles, kidneys are vulnerable to severe blunt trauma, where they can be crushed against the vertebrae,
Right.
causing rapid blood loss due to their high blood flow.
High flow means fast bleeding.
Exactly. Kidney tumors tend to spread along the renal vein. Renal pain can range from a dull ache to severe flank pain radiating to the lower abdomen, caused by stretching of the kidney capsule or spasm in the renal pelvis.
The embryological development of the kidneys is a fascinating journey. The permanent kidney develops from two sources, eventually ascending from the pelvis to its adult position due to body growth, becoming vascularized by successively higher aortic branches.
They climb up during development. This complex development can lead to several anomalies. Polycystic kidney disease is a hereditary condition where kidneys are enlarged and riddled with cysts. A pelvic kidney results from arrested ascent. It functions normally, but its unusual position can confuse diagnosis if inflamed.
Kidney in the pelvis. Wow.
Yeah. Horseshoe kidney occurs when the lower ends of the kidneys fuse, becoming trapped behind a major artery, potentially kinking the ureters and causing urine stasis and infection. These developmental variations are important to be aware of.
Following the kidneys, we have the ureters, the urine conveyors. These are muscular tubes, each about 10 inches long, that extend from the kidneys down to the posterior surface of the urinary bladder. Their primary role is to propel urine through peristaltic contractions, a journey assisted by the filtration pressure in the kidneys.
What's crucially important about the ureters are their three natural constrictions, which are common sites where kidney stones can lodge.
3 pinch points.
Exactly. These are first, where the renal pelvis joins the ureter, second, where the ureter kinks as it crosses the pelvic brim, and third, where it pierces the bladder wall. Understanding these narrowings is vital for diagnosing and treating ureteric stones.
Okay.
The ureters emerge from the kidney hilum, run vertically downward retroperitoneally on muscles of the back, and then descend along the lateral pelvic wall to the bladder.
Their relations are important for surgical awareness. For example, the right ureter is crossed anteriorly by the duodenum and major vessels, while the left ureter is crossed by the sigmoid colon and its vessels. The blood supply to the ureters is segmental, receiving branches from various nearby arteries, including the renal and gonadal arteries. Nerve supply comes from adjacent plexuses, with pain signals traveling with nerves to the spinal cord.
The clinical connections for ureters, despite their protected position, include rare traumatic ureteral injuries, mostly from penetrating wounds. Because they are retroperitoneal, urine extravasates into the retroperitoneal tissues. Ureter stones are a common and agonizing issue.
Kidney stones.
Ouch. Yeah. They often lodge at one of the three constrictions, causing intense colicky pain from smooth muscle spasm. This pain is typically referred to the flank, loin, and groin. If the stone descends into the lower ureter, the pain shifts further, referred to the testes or penis tip in males, or the labium majus in females, or even the front of the thigh.
Pain that travels a long way.
It does, due to shared nerve pathways.
Finally, within this segment, we turn our attention to the suprarenal glands, the hormone powerhouses.
Also called the adrenal glands. These yellowish retroperitoneal organs sit atop the upper poles of the kidneys. Their outer cortex secretes vital hormones like mineralocorticoids, essential for fluid and electrolyte balance, glucocorticoids, which regulate metabolism, and small amounts of sex hormones. Their inner medulla, meanwhile, produces the crucial fight-or-flight catecholamines, epinephrine, and norepinephrine.
Cortex and medulla doing different things. The location and description of these glands are distinct. While surrounded by renal fascia, they are separated from the kidneys by perirenal fat, residing in their own compartment.
Separate compartment, that's key. The right suprarenal gland is pyramid-shaped, capping the right kidney and lies behind the liver. The left suprarenal gland is crescentic, situated along the medial border of the left kidney, behind the pancreas. Both glands rest posteriorly on the diaphragm.
Their blood supply is multi-arterial, typically receiving superior, middle, and inferior suprarenal arteries from the inferior phrenic, aorta, and renal arteries, respectively. However, they each have only a single vein. The right suprarenal vein drains directly into the inferior vena cava, while the left drains into the left renal vein.
Left one drains into the renal vein, that's important. Lymphatics drain to the lateral aortic nodes, and their nerve supply consists of preganglionic sympathetic fibers from the splanchnic nerves, primarily targeting the medulla to stimulate hormone release.
The clinical connections for the suprarenal glands are significant due to their potent hormonal output. Cushing's syndrome results from an excess of cortical hormones, causing symptoms like a moon face and truncal obesity.
Excess cortisol.
Addison disease, or adrenocortical insufficiency, is characterized by increased pigmentation, muscle weakness, and hypotension. A pheochromocytoma, a tumor of the medulla, causes high blood pressure due to excessive catecholamine production. Surgically, the separate compartment within the renal fascia allows for easy separation from the kidneys.
The embryological development of the suprarenal glands is a two-part story. The cortex develops from tissue lining the body cavity, while the medulla originates from neural crest cells that migrate in. Importantly, the gland has a large fetal cortex at birth, which makes it particularly susceptible to trauma and severe hemorrhage during its involution in the first few weeks of life.
Fragile at birth.
Key consideration for newborns. Okay, let's connect this to the bigger picture and examine the posterior abdominal wall, which is far more than just a backdrop. It defines the retroperitoneal space, lying behind the parietal peritoneum and extending from the lower chest down to the pelvis.
That space behind everything.
Pretty much. Its floor is formed by strong muscles, like the psoas and quadratus lumborum. This space is a crucial embedding ground for many vital structures we've discussed. The suprarenal glands, kidneys, parts of the colon, the duodenum, ureters, and major blood vessels, all cushioned within fatty connective tissue.
This retroperitoneal space has significant clinical relevance. Palpation in the lower back and flank can reveal tenderness or muscle spasm, suggesting underlying kidney disease or irritation. Imaging like CT scans are invaluable here, able to detect air and extraperitoneal tissues indicating a visceral perforation or precisely define the extent of injuries.
Seeing air where it shouldn't be.
Exactly. Crucially, infections from retroperitoneal organs like the kidneys or a retrosical appendix can spread widely within this space. Even leaking aortic aneurysms may be temporarily confined here before a catastrophic rupture into the peritoneal cavity, making this space a critical area for managing trauma and disease.
Let's trace the major posterior abdominal wall arteries, starting with the powerhouse, the abdominal aorta. It enters the abdomen from the chest, descends anterior to the lumbar vertebrae, and famously bifurcates into the two large common iliac arteries around the level of the belly button.
The big red pipe.
Right. On its right side lies the inferior vena cava, while the left sympathetic nerve trunk is to its left.
The aorta gives off a complex array of branches. We have three anterior visceral unpaired branches: the celiac, superior mesenteric, and inferior mesenteric arteries, which supply the gut.
Celiac, SMA, IMA, the gut arteries.
Then there are three lateral visceral paired branches: the suprarenal, renal, and testicular or ovarian arteries. For the lateral abdominal wall, there are the paired inferior phrenic arteries and four pairs of lumbar arteries that supply the back muscles. Finally, it terminates into the two common iliac arteries and a small median sacral artery. That's a lot of important highways for blood.
It really is. The common iliac arteries originate from the aorta, descending laterally, and then divide into the external and internal iliac arteries. A key anatomical landmark is that each ureter crosses the anterior side of the common iliac artery precisely at its bifurcation.
Ureter crosses the bifurcation.
The external iliac artery continues along the pelvic brim, eventually becoming the femoral artery as it passes into the leg. The internal iliac artery then descends into the pelvis, supplying structures there.
Here's where it gets really interesting clinically. Aortic aneurysms. These localized dilatations of the abdominal aorta, usually below the renal arteries, are often due to atherosclerosis and are more common in elderly men.
A ballooning of the aorta.
Right. They're treated either by open surgical repair or, increasingly, by endovascular stent grafting. An embolic blockage of the abdominal aorta can occur if a clot from the heart lodges at the aortic bifurcation, causing severe lower limb ischemia.
Cuts off blood to the legs.
And the obliteration of the aorta or iliac arteries due to gradual atherosclerosis causes classic symptoms like claudication, leg pain on walking, and impotence. Interestingly, collateral circulation, alternative blood flow pathways, often develops to try and compensate, but it's frequently inadequate to prevent symptoms.
Now, for the posterior abdominal wall veins, dominated by the impressive inferior vena cava, IVC. Formed by the union of the two large common iliac veins in the lower back, it ascends to the right of the aorta, passes through the diaphragm, and drains into the right atrium of the heart. Its relations include the right sympathetic trunk and the right ureter.
The big blue pipe next to the red one. The IVC's tributaries are quite specific, and it's important to remember that they don't simply mirror the arterial branches. We have the hepatic veins from the liver, the renal veins from the kidneys, the right suprarenal vein, and the right testicular or ovarian vein.
But the left gonadal vein goes to the left renal vein, right?
Exactly. The left ones drain to the left renal vein. Also, the inferior phrenic veins and the lumbar veins drain into it. This detailed understanding of drainage patterns is critical.
While the IVC handles systemic return, the portal venous system is a separate, vital network. It collects blood from most of the GI tract, spleen, pancreas, and gallbladder, directing it to the liver for processing before it joins the general circulation.
Blood from the gut goes to the liver first.
Correct. Key players include the inferior mesenteric vein, draining the distal large intestine and joining the splenic vein. The splenic vein from the spleen's hilum joins the superior mesenteric vein behind the pancreas neck to form the portal vein. The superior mesenteric vein drains the small intestine and proximal large intestine, also joining the splenic vein. These three converge to form the portal vein, which then ascends to the liver.
Now, for some crucial clinical connections concerning these major vessels, abdominal aorta trauma, particularly from blunt force like car crashes, can cause rupture of its inner layers due to compression against the vertebrae, followed by external rupture from blood pressure, a surgical emergency.
Seatbelt injury, for example. IVC trauma is often lethal despite low pressure due to its inaccessibility, thin wall, and extensive tears. IVC compression is common. An enlarged uterus during pregnancy can cause ankle edema and temporary varicose veins.
Swollen ankles in pregnancy.
Malignant retroperitoneal tumors can also block the IVC, leading to dilatation of its tributaries, forming a caval shunt, which can be visible as enlarged superficial veins on the thoracoabdominal wall.
What's truly fascinating here, and critically important clinically, are the portal systemic anastomoses. These are vital collateral routes that become engorged and varicose if the portal vein is obstructed, leading to portal hypertension.
Backup routes opening up. Our source highlights 4 key sites. First, at the lower esophagus, where veins connecting the portal system via the left gastric vein to the systemic system via the azygos veins can rupture, causing severe vomiting of blood.
Those esophageal varices we mentioned?
Exactly. Second, in the anorectal region, where connections can cause hemorrhoids. Third, around the umbilicus, where connections to superficial abdominal veins can dilate, creating a caput medusae, a radiating pattern of visible veins.
Veins radiating from the belly button.
Right. And fourth, in the retroperitoneal space, where veins of retroperitoneal organs connect to systemic veins. Understanding these sites is crucial for recognizing the signs of portal hypertension.
These anastomoses are directly implicated in portal hypertension, which often also presents with an enlarged spleen due to blood backing up. Surgical procedures called porticoval shunts are sometimes performed to relieve this pressure,
creating a bypass. It's also worth noting that due to the way blood flows into the portal vein, the right liver lobe primarily receives blood from the intestine, while the left lobe receives blood from the stomach and spleen. This pattern can actually explain the distribution of secondary malignant deposits, cancers that spread in the liver.
Wow, blood flow patterns affect cancer spread. Turning our attention to the posterior abdominal wall lymphatics, the lymph nodes are intricately arranged along the aorta. We identify 2 main chains. The preaortic lymph nodes, which cluster around the origins of the celiac, superior mesenteric, and inferior mesenteric arteries.
Following the gut arteries, these collect lymph from the entire GI tract, spleen, pancreas, gallbladder, and most of the liver. Their efferent vessels converge to form the large intestinal trunk.
Then we have the lateral aortic, or para-aortic lumbar lymph nodes.
On the sides of the aorta, These drain organs like the kidneys, suprarenals, gonads, and deep abdominal walls. Their efferent vessels form the right and left lumbar trunks.
These major lymphatic trunks eventually converge. The cisternaculi, an elongated lymph sac located just below the diaphragm, is where the thoracic duct begins.
The start of the thoracic duct. It receives the intestinal trunk and the right and left lumbar trunks, along with other small lymph vessels from the lower chest, making it a crucial collection point for lymph from the abdomen before it returns to the bloodstream.
Now let's explore the complex tapestry of the posterior abdominal wall nerves. The lumbar plexus, formed by the nerves from the upper four lumbar spinal segments, L1 to 4, is intricately woven within the psoas muscle.
Nerves running through the muscle. This plexus gives off several key branches. For example, the femoral nerve, L2-4, supplies major muscles in the thigh, and the genitofemoral nerve, L1-2, with its genital branch, is responsible for the cremasteric reflex.
The nerve for the thigh and that reflex, these nerves are crucial for abdominal wall sensation, lower limb movement, and certain reflexes, linking the abdomen to the lower body.
The sympathetic trunk, abdominal part, is a direct continuation of its chest counterpart. It runs downward along the vertebral bodies next to the psoas muscle. It typically has 4 or 5 ganglia. Its branches carry nerve signals to blood vessels, sweat glands, and muscles, and also contribute to large nerve networks around the aorta.
Surrounding the abdominal aorta, we find the intricate aortic plexuses, a dense network of sympathetic, parasympathetic, and sensory nerve fibers. Regional concentrations of this plexus form the celiac plexus, around the celiac artery origin.
The solar plexus.
The renal plexus, around renal arteries, and the superior and inferior mesenteric plexuses around their respective arteries. These plexuses are the command centers for involuntary innervation of the abdominal organs.
A relevant clinical connection here is lumbar sympathectomy, a surgical procedure performed to induce vasodilation in the lower limbs for certain circulatory disorders by cutting sympathetic nerve fibers.
Cutting nerves to improve blood flow.
Right. However, a bilateral procedure can, in males, lead to a loss of ejaculatory power while erection remains unimpaired, highlighting the delicate balance of autonomic nerve system function.
Now let's bring it all together and apply our detailed anatomical understanding to abdominal pain. Somatic, visceral, and referred. This is where the rubber meets the road in clinical practice, allowing us to differentiate causes and pinpoint locations, just like with our appendicitis patient.
Absolutely. Somatic abdominal pain originates from the abdominal wall, the skin, muscles, and, crucially, the parietal peritoneum. This type of pain is severe, precisely localized, and often felt on one side of the midline. The impulses travel via specific segmental spinal nerves.
Sharp, localized pain.
Exactly. An inflamed parietal peritoneum is exquisitely sensitive, causing cutaneous hypersensitivity, tenderness, and reflex muscular rigidity, known as guarding. This guarding is a protective mechanism to keep the inflamed area at rest. Rebound tenderness, where pain is worse when pressure is released, is a classic sign here.
Guarding and rebound.
Our appendicitis patient, in the later stages, experienced this precise, severe, localized pain in his right lower quadrant when the inflammation reached his parietal peritoneum.
In contrast, visceral abdominal pain arises from the abdominal organs themselves, the visceral peritoneum or the mesenteries. It's typically dull, poorly localized, and often referred to the midline.
Dull, vague midline. This midline referral is thought to be because the organs develop embryologically as midline structures and initially receive a bilateral nerve supply. Causes include stretching of an organ or its mesentery, distension of a hollow organ, impaired blood supply, ischemia, or chemical damage.
Colic is a violent form of visceral pain, right?
Yes, caused by spasmodic contraction of smooth muscle due to luminal obstruction, like an intestinal obstruction or gallstone passage. Visceral pain is often accompanied by reflex symptoms like sweating, nausea, vomiting, and increased heart rate. Our appendicitis patient's early pain, a dull ache around the belly button, was visceral.
This leads us to referred abdominal pain, where pain is felt at a location distant from the site of origin, but within an area supplied by the same or adjacent spinal cord segments. The brain simply cannot distinguish the true origin.
The brain gets confused. Let's look at some classic examples. Stomach pain is commonly referred to the epigastrium, upper central abdomen.
And looking back to our initial case, early appendix pain, caused by distension or spasm, is referred to the umbilical region. But crucially, if the inflammation spreads to involve the parietal peritoneum, the pain then shifts and becomes the precise, severe, and localized somatic pain in the right lower quadrant that our patient presented with.
That classic shift again.
Yeah.
Similarly, gallbladder pain, like in biliary colic or cholecystitis, is referred to the lower chest or upper abdominal wall. But if the diaphragm's peritoneal surface becomes irritated, pain can be referred to the right shoulder due to shared nerve pathways from the phrenic nerve.
Shoulder tip pain from the gallbladder. Understanding these intricate pain pathways is foundational to accurate diagnosis.
To truly master abdominal anatomy, visualization is paramount. The diverse contents and complex topography of the abdomen necessitate a variety of imaging tools. Radiographic anatomy relies on X-rays, CT scans, MRI, and ultrasound, each providing unique insights into the condition of this area.
For plain film X-rays, specifically an anteroposterior view, we systematically examine several features. We look at the bones, the lower ribs, vertebrae, hip joints. We also check the diaphragm, the distinct shadows of the psoas muscles, the homogeneous opacity of the liver, and sometimes a soft shadow for the spleen.
Looking for outlines and gas patterns. The kidneys are often visible due to the surrounding fat, and we look for gas in the stomach and intestines, fecal matter in the colon, and a filled urinary bladder shadow in the pelvis.
For the GI tract, contrast studies using barium sulfate are invaluable. With a barium meal, the stomach shape, gas bubble, and peristaltic waves can be observed. The duodenum initially shows a smooth duodenal cap in its first part, then a floccular appearance in the remainder due to its internal folds.
Watching the barium move through. In the jejunum and ileum, the barium spreads out due to mucosal folds and peristalsis. For the large intestine, a barium enema is often more satisfactory, outlining its characteristic saculations, haustra, and mucosal pattern, and may even fill the appendix.
The biliary tree isn't visible on plain film X-rays, so specialized imaging is used. Oral iodine compounds are concentrated by the gallbladder, making it visible as a pear-shaped opacity.
Making the gallbladder show up. A fatty meal then stimulates its contraction, making the cystic and bile ducts visible as the opaque medium passes. Sonography, or ultrasound, can also clearly show the lumen of the gallbladder and detect stones.
Ultrasound is great for gallstones.
Very good. For the urinary tract, kidneys are usually visible on plain film, but the collecting system and ureter are not. Intravenous pylography, IVP, involves injecting an iodine compound intravenously. It's excreted and concentrated by the kidneys, rendering the calyces, renal pelvis, and ureter opaque, making them visible.
Lighting up the urinary tract.
Exactly. This allows us to trace the ureter course, clearly showing those 3 normal constrictions where stones often lodge. Retrograde pylography provides a more detailed view by directly injecting contrast into the ureter via a cystoscope.
For truly understanding the complex 3D relationships of abdominal structures, cross-sectional abdominal anatomy, primarily through CT and MRI scans, is essential.
CT and MRI give you those slices. These detailed images allow clinicians to interpret the intricate layering and interconnections of organs, vessels, and tissues in a way that traditional radiography cannot, offering an unparalleled view inside the living body.
While not detailed in our provided sources, it's worth noting the importance of surface anatomy.
Definitely. This involves understanding the external landmarks on the body that correlate with underlying internal structures. These external signs are crucial for physical examination and palpation, allowing clinicians to infer the condition and position of internal organs, directly connecting what we see and feel on the outside to the complex world we've explored within the abdominal cavity.
Wow. Okay, so from just a localized pain in the right lower quadrant, we've traveled through the entire abdominal cavity, meticulously exploring the peritoneal wraps, the winding pathways of the GI tract, the incredible functions of accessory organs like the liver and pancreas,
The kidneys, suprarenals.
the vital roles of kidneys and suprarenals, and the complex networks of vessels and nerves that make it all work. You've now gained, hopefully, an elite professional perspective on how deeply connected and beautifully organized this central part of our body truly is, right down to the microscopic structures and the embryonic origins.
What's truly fascinating here, and connects all the dots, I think, is how the earliest embryonic rotations, mere twists in development that happen before we're even born, dictate not just the final position of organs and their peritoneal coverings, but also the precise patterns of pain referral, the routes of infection spread, and even the vulnerability of specific arteries.
It all goes back to those twists.
It really does. It's a testament to the enduring fundamental impact of developmental biology on every single aspect of clinical practice and our understanding of human health.
So the next time you feel a twinge in your abdomen, consider not just where the pain is, but what kind of pain it is. Is it a sharp, precisely localized somatic pain of the parietal peritoneum, signaling direct irritation?
Sharp and specific.
Or a dull, poorly localized, and possibly referred visceral pain, hinting at a deeper issue within an organ itself.
Dull and vague.
Understanding these distinctions empowers you to not just observe your body, but to truly listen to its incredible complex story. What aspect of this intricate abdominal world will you be paying closer attention to now?